Do you guys get that part? So your screw and your abutment, again, are two separate components, two separate entities. When you're working with these things, component goes in, you feel it click into place, and then you tighten it. So it's not always a matter of tightening the entire thing together as one. Another thing, if you haven't worked with implant screws, when you loosen it, certain of these abutments don't just come out of the implant. Because of the connection and the seal that it has, the abutment stays locked in within the implant, even if the screw is loose. And there's times when your screw isn't loose and you're going to try and pull something out and something will break. The easiest way of knowing that your screw is loose is that while loosening it, once the screw is completely loose, you feel or you hear a little click on the screw. So the screw almost starts jumping or clicking or pushing back on your abutment, or on your screwdriver rather. When you feel that click, then you know it's all loose. Extraordinarily, and this is actually a cool way of seeing it. Do you have that abutment holder? Let's pop it up here. So you guys are not going to go through all of this. I'm just doing this for a bit of background. That's what your abutment looks like on the analog. So if you imagine your impression or your model, that's what these two things would look like when they come together. When you've got your crown, that's how the crown would seat over this entire guy. The cementation part is different to crowns in the mouth. Remember, crowns in the mouth have your fibers and ligaments and periodontal ligaments all the way around those two. So any cement that goes into your sulcus when you're cementing a crown will inadvertently be pushed back up. Whereas if you're cementing an implant crown in the mouth, that cement goes all the way down into the peri-implant tissue, and then that implant can fail. Worst case. So now he's like nodding because that's the biggest enemy, cement that goes down there. So respecting the cementation process of a crown intraorally is of critical importance for the longevity of this implant as well. So it's not a matter of cement, pop it in and all out. Your other aspect or your other part to take heed of is this crown doesn't have an opening up here. Okay, so there's no opening, there's no screw access hole, and your screw sits within the space here. Okay, Gavin's going to bring it back into focus. That little purple guy is your screw. Straumann makes implantology very easy. If you drop cement into this crown and you bring the two together, that cement will fill up the screw access hole. And that's exactly where your plumber's tape comes in. Does that make sense? Plumber's tape to protect the screw from cement or composite or resin or whatever material you're working with down there. I didn't ask Yusuf, but if I have to put this, Yusuf, he told me don't ask him questions. If I put this abutment back onto the model, the crown will fit in any position. It's like a classical technician answer. Basically what I'm asking him is, I've taken this abutment off the model, and when I put it back, because this abutment has those engaging bits at the bottom, this abutment can engage into this implant in different positions. Let's see if he's made our life easy for us. Yeah, well done. So it fits on there normally. So what this tells me is if I'm able to now play with my abutment outside of the mouth, if I'm able to play with my abutment outside of the mouth and then get it back into the mouth and it seats, I can do extraoral cementation predictably. Is it not on screen? My crown's on screen. Yeah. So basically the crown or the abutment's under this here. So which basically now tells me that I can cement this extraorally, clean up my cement and the excess that has overflowed, and then cement it into the mouth and then deliver the crown into the mouth afterwards. You guys got this so far? Sorry? How do I secure which part?
The abutment
into the implant?
Yeah.
With the screw that's in the middle of it. Okay, so I'm going to run through this process, so just pay attention here so you don't lose me. Do I have cement here? Henda, is Henda here? Henda, do you have cement and a curing light, please?
Curing lights is and over. And we have permacene, universal and permacene too.
Okay.
Yeah.
Maybe I'm just going to use the composite to cement it.
Yeah, you can
Yeah.
continue for the curing light.
I don't want to waste your guys' expensive material, but I know that it's here. I don't want to waste. We'll use the delegates to use the cement, and I'll just use the composite. Okay, so here we go. So we take this out. Okay, you guys can see here. Talia's been amazing and got us abutment holders, so it makes our life a lot easier. So you'll take off your abutment, you get it onto the analog, it engages into place, and you've got your unit sitting as one. Okay, you guys follow. Abutment out of the mouth onto an analog, and then I get this onto this little analog holder. Okay, so an analog holder is basically this little Straumann tool that you see here, and that just allows me to work with the implant on an analog, and it's not this small little device in my fingers anymore. So if you're grinding, adjusting, cementing, you're working with something that's a little bit more ergonomic. Okay? When you're looking at your abutment, remember the screw access hole. Gavin's going to be playing around with your focus again. That's your screw in there, and this is where the plumber's tape comes in. So it's quite a big piece of plumber's tape, eh? This is awesome. Haven't lost it. Okay, so I'm going to hold it up like this here. You got your little guy, your plumber's tape, you get it into your abutment itself. Do you have a probe? Sorry?
Yeah.
Yo, okay.
Yeah.
Do you have an instrument that I could pack this quicker with?
No, the plastics unfortunately we have, but yeah.
Okay, but I got it in. So in essence, you now have got your... Okay, there we go. So that's pretty much what you want. All you're doing is putting your plumber's tape over your screw access hole, so your screw is now completely closed and protected. Saying you're good.
No, it's fine, but do it as an intraoral cementation.
You do intraoral cementation.
Yeah, because you still might not get the contact right. Because the abutment might go down, but you might not get the crown orientation.
Okay, so Dr. Singh wants me to do an intraoral cementation. Let's get this out.
The extraoral cementation will only work if you have a model. Otherwise, there is a slight error in the thing.
It'll work only if there's a model.
Yeah.
Okay, now.
If you have an actual model.
Okay, so we're imagining the model is a patient's mouth.
Yeah, you can do it in the mouth or on a...
Yeah. So let's get our friend up here.
So I think everybody make sure that your titanium abutment is accurately on your implant. Screw down at sufficient finger tightening. Screw down the screw and pack your PTFE tape or plumber's tape in.
Yeah.
Everybody do that, and then I'll walk around and just see that it's okay, and then we move on to the next step. So when we get to that point,
We're going to have to take the PTFE tape around to everyone though.
I think they did already.
Or did they?
Yeah.
you want to pack the tape so that it's level with the top of the cylinder.
Smaller piece. Here we go. Okay, so that's pretty much what you want to see on your models right now. You want to see your PTFE tape covering the top part of your cylinders. So basically at this stage you have two options. There's two ways of doing it. The one way is if you were going to cement your crown, you could put your cement into your crown and you pop it through here, and you cement it like that. What's the biggest problem with that way? Sorry? Excess going to flow. So you need a vent for excess to be removed. There's a lot of literature out there on how to cement safely and pre-trials and things like that there. But in essence, you need a vent. You don't want all of this pressure going down. So to make a vent, we need to actually make a screw access hole that will open us to the opening up here. So in essence, you're digging or you're mining to find this hole now. You've got to be careful, because if you're going to drill too much, you're going to crack the crown. If you're going to drill too little, you're not going to find this hole. So Jean says he doesn't do live demos, and I guess this is why he doesn't do it, because if because if you stuff it up, you only got one chance of doing this. You can see up here, so you kind of got to just eyeball where you think this hole is, and then Talia's, Henda's here. Can they see up there? So now you start seeing, sorry Kevin. Okay. So now you start seeing your access hole slowly coming into view. And this is why it's important that you have your PTFE tape right at the top, because now you start picking it up and then you get it back down there. Yeah, there we go. So now you can see I just need to open up a little bit more distolingually or distopalately, so I've got a proper complete access opening, and then we should be good. Okay, there we go. So that's kind of your endo access opening that you'd want there. It's still important that you see as much of this opening as possible, because your screwdriver is obviously going to go down one way into that screw hole itself. You don't want to be engaging your prosthetic screw at not 90 degrees onto it. Inda, can I get a blower quickly? And I just clean this up. Okay, are you guys still with me here? Yes. Okay, so now at this point is where I'm going to take a bit of a break. You would want your screw access hole to look something like this. Okay, so there should be hand pieces and number 8 round burrs or those rosehead burrs on your desk. There's a can of little air duster, compressed air, to blow out any excess dust that's around there. But for all intents and purposes, this is what you want it to look like. Gentleman was, can I not just drill from the inside surface of the crown outwards? And you can't, because you won't have an idea of where that abutment is sitting. So you always look at, see where the buccal lingual type of relationship is. Okay guys, have a look here quickly. So this one here, he can see the tape. So he asked me, does he stop drilling at this point here? And the answer is no. But when you're working with your handpiece, try to work vertically down the tooth. Okay, so you hold the handpiece vertically down and not on the side in this way here. If you work vertically down the long axis, you're going to create a more straight, more conservative opening. So think of endo again. You're not opening anything wider than what you need to. So you tell the laboratory to make the crown, make the abutment, don't cement it together. So if there's any discrepancies, I can reline it to fit in the mouth. So look, in essence, it's a good question, because why would you take an impression to have a model for the technician to make a crown that fits on your temporary abutment, that fits into the mouth, and we doing it this way? Simply for the learning purposes, you guys are now getting a better orientation of screw, implant, abutment, occlusal surface, angles, plumber's tape. You're managing all of these various elements in this case. So when we actually get to making the provisional the way we need to make it, you already have a three-dimensional orientation of what's happening under the crown. If we went straight into making the crown immediately, for you to work backwards becomes a bit more of a challenge. There's probably been one or two cases where I actually did this chair side, but more often than not, you'll never do it like this. Yeah. Station, we have permacem here today. Look, you need to think of your materials, and I think resin cement becomes a better way to go. You still think about your color and shade as well. Remember, if your abutment sits quite far buccal and you're using the wrong color cement, that will also shine through. So don't forget those fundamentals of shade selection with your cements. What's going to happen here is you're going to drop a very little bit of your cement into your crown. Ashen, you'll stop me if something you don't.
Okay, come back to the screen. So you squirt some of your cement out. It's not good. Yeah, there we go. Pull that one.
Look, you don't really need that much. But if you see immediately, okay, I should put more. This is what probably would happen. You end up with cement up here, and you end up with cement that's going to fill up the top there. And that's why that plumber's tape becomes so important, because once you get this on here, you see immediately you start getting this pushback that comes through, and that vented hole now allows you to let the excess or most of the excess come through. You obviously can't see it now, but when I take it out, we'll see that under this, there's definitely a lot more cement that's seated. Now's the opportunity to try and clean up so you get less mess that's happening underneath for finishing your curing light.
So those little micro applications that you use for adhesive is something else to use.
Yeah. Do you have a curing light?
Clean up
A
the
curing light?
as best you can, but no matter what, you will still have to drill it open a little bit again. There you go. You guys each have one of those in front of you. And just watch first before you do it.
So once you've got it in there, you've pretty much now, you can see your opening. What's nice to see is that you end up with slight void. So if you open up too much and you make this opening wider than what it needs to be, then you're going to be filling up the space with cement. So you want to still keep as much of solid material as possible. So that's why that access opening becomes so important. You're not moving your crown around, you're keeping it in place, and then recuring it. Yeah, there we go. So now you've basically got it cleaned up and all of the excess is out. I don't know if it's happened to you. Sometimes you can't get your probe all the way down there. So I end up using an old endo file to grip it, and yeah, basically that's.
Yeah, so if you're having trouble, if you pack too tight and the probe can't get it, you can use an endo file or a barb broach. Just get in there and hook the PTFE and pull it out.
And now from here. So this is the point where you feel that clicking sound. So once the crown is complete, once your screw is completely loose, you hear that click or you feel that click. This is why Jean doesn't do hands-on like that. Let's get it to cement. There we go. And that's what it should come out looking like. But what you can see very carefully, and look, we talk about magnification for endodontics, but magnification in implantology is equally as important, because if you look around the lingual or the palatal surface of that, you've got excess cement that's there. And that cement also needs to be removed. So it's attached there, but soft tissue hates that resin. You'll end up with recession or some sort of mucositis in that area. And you're going to polish this entire base off. you want to add anything to that?
No.
Okay. So I think at this stage, let them cement and then we can polish up.
Let's get to this point here.
You've now taken out your implant crown from the mouth, and now you've got this excess material that's sitting around the palatal or lingual surface. Okay? We're going to go through the finishing and polishing of this part of the crown when we do the actual hands-on on your tooth number 2-1. But what's important for you to know at this stage is that even though you've got an implant in the mouth and you've got the situation as it is, you still need to have an analog with you on hand. Because if you imagine, how do you grind and polish and work this thing in the mouth without chopping off your fingers? You're going to be working with discs and burrs. It will become dangerous. So you have a spare or an old analog. Sorry? Artery forceps will scratch and damage the crown that you've been polishing. So first put the analog on, and then the artery forceps on the analog. That's why Jean is class captain. So that's what it would look like. It's obviously really, so at this stage, you can now use an artery forceps to hold this part of the crown in this way here to start finishing. It helps a huge amount if you've got this analog holder type of device, because now you're able to put your analog onto something that has a longer arm, and you can polish and shape on this level here. Does that make sense to everyone? Yeah. Does everyone's crown look something like this? Good question. Okay, so the question was, sorry guys, just pay attention. So the question was, what happens if you underfill and there's voids and there's gaps there? You've basically now incorporated weak spots into this, and there's a very good chance that that crown can now crack, because it's obviously an empty, hollow air bubble. It's the same thing as an air bubble under composite filling, the impact of that. The thing here is it does make a bit more work for you, because now you've got to directly drill through that opening, create another little hole, fill up that area with composite or restorative material, and then polish and clean afterwards. It's not ideal. You don't want to be doing it like that. So that's why that initial phase you don't want to stuff up. Yes. Didn't add anything to that? No. Okay, so don't stress about cleaning off the excess as yet. We're going to clean off the excess from this one once we've done the next hands-on, where we've actually done the shaping and the contouring of it. So the other question that I got earlier from, I think it was David there, was, again, this situation will never happen in your practice. Very, very rarely, if ever, will you take an impression, your technician pour a model, your technician make you a provisional crown, and not have it cemented or luted onto your cylinders, and then expect you to do it chairside. It's almost never going to happen. So don't overthink that part. The most important part is that at this stage, you've now got familiar with working in the different dimensions and spaces around this implant crown.